Can people see my screen now?
Yeah, that should be
Yeah.
fine. We
Yeah,
have to go in the, yeah, that's fine.
that's fine. Well, thank you very much, Vikram. Vikram and I are long friends, long-standing friends, and I'm so grateful for this opportunity that Vikram has given me to be associated with the quality improvement projects. I know Vikram is very much dedicated to the care of newborn babies, and he referred to the Oxford Fellowship Program. And I think I think it's a proud thing for us to have achieved. We've got over 85 doctors now who have come from India, who come into Oxford for 2 years and are able to both contribute to looking after the babies who are born in Oxford, but also hopefully learn something and go back to India. So this has been a great opportunity, and if there's anything that I'm really pleased and satisfied after leaving India, my home country, is I feel satisfied that I've been able to do something like this. So thank you very much. Um, Vikram had asked me to talk about quality improvement, and in during the time of COVID. And I looked at this quote, and it was Winston Churchill who said, "Never let a good crisis go waste." I think he was talking in jest, but I think there's some truth in it. Um, Crises come, and I think we've got very little control as to what we can do with crises, but we must try and to do what we can. This is the deaths in the UK, the graph. I mean, this is a horrible graph. I mean, this is my pointer can show. This is around the period of March, April. At that time, UK was losing approximately 1,000 people a day. This is per day. And from here, from March right up till the middle of July or August, we were in a perpetual crisis situation, and we were no different to many of the countries that are around the world. And sadly, we are now reaching a point that the number of deaths in UK are climbing again. So the crisis hasn't gone away, and it's coming back. And so this is something so what we have done in this crisis period um, is unprecedented in the sense that it is really something that nobody anticipated, nobody knew where to go. What happened on the neonatal unit? Well, I use the word COVID shock. We were in COVID shock, you know. We didn't know what hit us. You know, in March, we started losing people left, right, and center. Some of our nurses lost their lives. Some of our porters died. I lost my colleagues who were hit with COVID. Um, as a newborn lead and the clinical lead for newborn services, it was particularly challenging because the advice from the government changed virtually weekly. We had a PPE nightmare: what to use, when to use, how to use, who to test, whether testing was available or not. And the most important impact of all of that was that we had virtually had to stop a large number of our existing projects. And we started focusing on the here and now. We were running a, a successful project in NEC prevention. We had to scrap it. Our delayed cord clamping program had to be stopped because there was a lot of training going on and we couldn't carry on. We had set up a program of using an oxygen calibration, automatic calibration with our high flow and ventilators. That had to be stopped. So the QI project stopped. Research on the unit stopped. And we were in complete crisis mode. Um, I the cycle of any quality improvement has plan, do, study, and act. And I think what we went from all of that is to do stuff. And some of the quality improvement projects that I'm going to talk about was born out of necessity. And I think it's important to remember that we did not have enough time to plan a lot, but we had to do. So I will briefly talk about 2 or 3 projects that we undertook in this crisis period. The first project I would like to talk about is our antibiotic clinic, which we set up. The second crisis, QI, as I say, was connecting babies with mothers, not connecting with babies, babies with mothers and fathers. And the third one was, what do we do about the tremendous amount of psychological trauma that our staff are undergoing, and what could we do to improve the psychological support? So I'll briefly touch on what happened in each. So we set up something called the Ambulatory Antibiotic Clinic in Oxford, and I think we were the only unit in the country which did that, and we've put it up for in a it is we've set it up for publication very recently. What was the need, and what was the ambulatory clinic all about? The driver was that we had mothers who we wanted to send home early. Now, these mothers, we did not know whether they were COVID positive or negative, but in in our postnatal wards upstairs. Our postnatal wards are on the floor 5, 6, and 7, and many of the mothers were COVID positive. Some of them we did not know, but we wanted to reduce the exposure of mums to COVID-19 and mums with COVID-19 to the rest of the staff. And we realized that a large number of mothers often remained inpatient on account of treatment for babies. So babies who had septic screens, who were on antibiotics, we did a quick screen and we saw that, you know what, babies who are on 4 or 5 days or longer number of antibiotics, they clinically tended to become well in 2 days. So there was some potential of these babies to be sent home early. It was risky, but we were trying to think how to manage that. If we did an early discharge with a baby who is on antibiotics with a cannula, um, we were taking a risk if the baby became unwell at home. That could be one of the problems. But also the baby and mom could be at home away from COVID, and perhaps it might um, facilitate breastfeeding. We don't know. But the driver was get mothers out of the hospital as soon as we can, reduce exposure. So the challenges, of course, was our usual antibiotic that we use was benzyne penicillin, and gentamicin. That is what our usual antibiotic was. So we got a group of 4 or 5 clinicians and a pharmacist together, and we immediately first changed our cefotaxime to change the antibiotics to cefotaxime. So instead of having benzyne penicillin and gentamicin, gentamicin means that we have to go and measure gentamicin levels, and that exposes our junior doctors who are taking bloods. We've decided to change to cefotaxime twice a day. But the challenge was, if we had to send these babies home on antibiotics, could we consider ceftriaxone? I know that ceftriaxone has been used for intramuscular use, and people have used ceftriaxone intramuscularly. But the challenge with that is that it's a painful injection, and the bioavailability of ceftriaxone intramuscular is not very well studied. There is also a risk of it displacing bilirubin and causing excessive jaundice. So our planning included first looking at the problem that we had, and our problem was getting mothers out. Number two, we looked at an antibiotic regime, we changed it to cefataxime. Number three, we started considering ceftriaxone. This is all happening in March. So this is when the crisis is hitting us. That's the beginning of March. We looked at the literature and we knew that FDA has eased restrictions on the use of ceftriaxone in infants, but nobody was using ceftriaxone in the UK for newborn babies. Nobody was using it. We phoned up and we could not find anybody who was using it. The advantage was that it was once a day. The disadvantage, of course, was it was a rare complication, or jaundice was a rare complication, but it perhaps could be monitored. But the biggest challenge we had was nobody did it before. And it took us quite a lot of convincing between us and the our pharmacy department and our colleagues to say, we are going to step into the unknown, literally. But we need to do something, because the bigger crisis is a lot of people in hospital are getting COVID, right? So we created. I mean, I remember sitting and creating a guideline almost in the middle of the night, and we said, okay, what we will do is we'll trial IV ceftriaxone on the unit, and we trialed it, and it actually, we didn't notice any side effects or anything. We made sure that we had some of our nurses trained for using IV ceftriaxone. And remember, ceftriaxone is an infusion, and the infusion lasts for about 60 minutes. So one of the challenges was we could send these babies home. They will come back from home, but each baby would need 60 minutes of an infusion time, and that was a challenge. Now, who's going to sit with the baby for 60 minutes, because you monitored the infusion? So we got one of the maternity support workers to help us. I mean, they would be sitting there and they would alert us if the pump was a problem or there was any issue. The antibiotic clinic was set up very close to the neonatal unit. So we knew that if there was a problem. Can people still see my presentation? I'm presuming people can. So
Yeah, we can, Amit. Please
yeah.
go ahead.
So we created this guideline, and we said, look, it has to be very clear what the guideline is. Each and everything. What is the? I've left this. This is the door code. So everything we should have it very clear. We had a little register. We were sitting on the unit, and we set up a system, all manual system, nothing very much electronic. And we set up a system of giving antibiotics. We used level 1 PPE for babies returning from the community. And we had one room where the antibiotic was given, and we set up another room where moms and dads could wait. So essentially, mothers and babies would drive up to the front of the hospital, go straight to the antibiotic clinic area with very clear instructions where to go, sit there, they would be called in. Where they were sitting, there was social distancing maintained. And this was happening in the end of March, beginning of April, right? But then we also altered our antibiotic pathway, because see, this is what was happening. It was happening on many fronts. And we said we need to shorten our antibiotic pathway. We reviewed all the babies who had antibiotics over the past 6 months. And we said, okay, if you have to complete a partial septic screen, which is without a lumbar puncture, you first do that, you give the first dose of ceftriaxone. 12 hours later, you give the second dose and you take the CRP. And now you check the CRP, right? If the CRP first or the second is less than 10, you do not give any further antibiotics. End of antibiotics. You send the baby home. That is it. If the second CRP is greater than 10, but less than 25, then you give 5 days of antibiotics. And you register the baby for the antibiotic clinic. But if the second CRP is greater or equal to 25, then the baby has a lumbar puncture. Sorry. Okay. So I go back again. This was again a change. This was COVID change. First or second hour CRP less than 10, do the observation, remove the cannula, give the mother a baby check-in leaflet and said, thank you very much. And phone the mother the next day and ask, is the baby well? End of story. That is only 2 doses and out. If the CRP is between 10 and 25, you then give 5 days of IV antibiotics, but you change to IV ceftriaxone if the baby and mama fit for discharge. And if it's greater than 25, the only difference is you do a lumbar puncture and you still maintain the same thing. You can send the baby home on IV ceftriaxone if the baby and mama are well. So we simplified our sepsis guideline. Between April, so April, May, June, July, August, September. So I'm talking 6 months. So the crisis hit us in March. And when I say hit us in March, we actually shut down in the UK on the 18th or 20th of March. So within 10 days, we set up the clinic. And the clinic started in the beginning of April. And the data I'm showing you is of 6 months. So the ones which had just 2 antibiotic doses, they're not obviously included. But the ones which had 5 days or above, 186 babies had this. 86 had antibiotics, which could be as in home antibiotics. And 100 of them were unwell enough or not, they were sick enough to not be eligible for the home antibiotic regime. Of the 86 patients, what we noticed that 20 of those babies just had the 1 day of antibiotic at home. So they were discharged on day 4. They were probably unwell because of respiratory distress and all that. We could discharge them in just for 1 day. But interestingly, 38 of these babies had 2 days at home. 17 had 3 days at home. 6 had 4 days at home. And 5 had 5 or more days at home. And I think it was a significant number of babies who, after we thought they were doing well, were being sent home for their antibiotic cover. The main reason for the antibiotics to be given was respiratory distress in 75% of the cases. There were other reasons like, abnormal temperature or feeding problems or so on and so forth. There were other issues which was the indication for antibiotic. And there was no data for about 6. But what I'm trying to say is 86 babies, vast majority of them had respiratory distress. Many of them were eligible for home antibiotics. And once the respiratory distress settled and the feeding was better, we sent them home. 2 days, 3 days, 1 day, 5 days, anything we sent was a gain. And our biggest fear was readmissions. And we were worried sick that what would happen is these patients will get readmitted. So what we did, in our regime, we said, once you go home, the next day when you come for your antibiotic dose, we will do a bili check, we'll do a bilirubin check, we will ask you how the baby is, and we won't examine, but we will just make sure that the baby is feeding okay and is otherwise fine. We didn't want to send a doctor every time to examine the baby. We just said that was what we would do. And this is every day we would do for the doses of antibiotics that we were given. Now, one baby of all the 86 babies was admitted on day 5 of home antibiotics, had some tachypnea, but was feeding. The baby was admitted for 1 day just for observation. And one baby was admitted on day 9 for poor feeding. That is it. The rest of the babies were well and happy at home and completed the dose of antibiotics at home. None of these babies were readmitted because of jaundice. We used a flash bilirubinometer. Have you seen one of the skin ones? You just place it on the skin. We just used those. We did not do spun bilirubins. We did not send anything to the labs. The other problem was cannulas. So how many cannulas were recited? 20 cannulas had to be recited. That is 10% of all the dose administered. I think that's important to know. So out of all the doses, 10% of the doses had to be a cannula reciting. And in summary, we found that once a day ceftriaxone use was safe, did not result in hyperbilirubinemia, and nearly half of the babies on day 5-day plus babies could 5-day antibiotic or more could benefit. The readmission rate was 2%, but I must say that this is not, these babies were not readmitted sick and in sepsis. They were simply readmitted for things that were very temporary. 10% of had cannula episodes. We saved 196 bed days, and I think that's a significant impact that we had on the obstetric services. So that was our QI project that we did. The important thing here to emphasize is, although we had to act very quickly, we made sure that the planning, although was concentrated, was done very thoroughly. We sat down, we made sure that we were as safe as possible. We created the guidelines. We spoke to all the nursing staff and medical staff and the midwives. And we were taking a risk because nobody had done this. And we were really worried from the trust perspective. If there was a baby who would become extremely unwell at home, what would we do? So there was a lot of teaching given to mothers and so on. So the planning had to be very well done, and we put it into action. Although I'm presenting you a 6 month data, I can tell you that I was so worried about it that I used to look at it on a weekly basis. Every week I would look at what antibiotic, what babies went home, who came back, and what was the problem. So we kept a very close eye on it. And we we were ready to modify things on the guideline. We did some minor modifications, but broadly, it worked very well. What we regret doing is not giving parents a feedback form to ask them what was their experience, and that is our oversight in planning. But overall, I think it has been a successful project, born out of sheer desperation. There's no other way to explain it. I wanted to also quickly talk to you about what we did for parents. Now, I'm not sure what happened in Delhi, but I have been talking to Vikram about restricted parental visits. But we had just the one parent visiting a baby. So it could be the father or the mother, usually the mother. We then extended that to having both parents at the bedside for intensive care. And we are still having that system where two parents can come and spend time next to the baby. But where social distancing is difficult, we operate a rota. We have one parent by the bedside for a certain number of hours, and then some other bed spaces can have two, and then we just rotate it according to a time schedule, and we give them a little leaflet explaining when is your slot, and parents are allowed to use that slot. These mothers who were the mothers who were delivering babies were extremely petrified. We had not known at that time what would the impact of COVID be on newborn babies. We now know that none of the babies that we had were COVID positive, but at that time we did not know that. So there was an extreme amount of stress. Mothers felt isolated sitting at home. Visitation was difficult. Parking was difficult. You couldn't enter buildings in Oxford. You couldn't enter the main building at two at a time. So there were lots of restrictions. We then decided that we would exploit a program which was there, which was a tablet program that we had. And we had just started using that. It's called We Create. This is a tablet program where there is an iPad sort of a thing with a camera. Every baby gets a password and a username, and it is all QR coded. So the baby has a QR code on the bedside. The parents get that QR code, and it then becomes a completely secure connection. So this iPad is used, and what nurses did was to take photos and videos of these babies at various times. And the parents could just log in using their special login number and code, and they could see the baby. It was not a live video, let me tell you. It was a collection of clips, videos, and pictures which the parents could feel connected. And this helped them tremendously because although this program did exist, people had such easy visitation that the only people who used this program were the people who were living far away. But now everybody started using it. And this is the kind of photo that we used to send. Nurses did that very quickly and used to send them across. So what was the QI in it? The QI in it was this, that we struggled to get nurses to do these videos as often as we could like them to. So we contacted the Oxford Medical School. We had 3 volunteer doctors who had their classes suspended because of COVID. They come and joined us. They started they were trained, and their job was to take photos and videos for all the babies and just keep transmitting them. So they did a huge amount of photo clicking and video making, and I think it was a great help to our mothers. And I'm just these are the kind of things that we send them. These are videos and clips that went to mothers, and the feedback that we got was excellent. We love these updates. Baby's dad gets up to see him every day. Updates are amazing. Thank you. We were worried of what the first night was going to be in the court. Nice to hear her and see her. She's settled. You're doing so well, little girl. You're so lucky to have these amazing people around you. And all these, this is just a snapshot of the feedback that we got from our parents. And I think our psychologists who were working on this do tell us that the parental experience and the connection actually improved quite a lot. As I said, 3 medical students, and we used the number of photos and videos sent increased by 250% between March to July. It's now become, now we're not using it as much, but now that the COVID is coming back, I think we will be starting to use it again. So this was one way that we found to connect. We had a very quick planning session. We got these medical students in, and right in, we started this. So this was also quite early on in the project. But the thing which we were also very worried about was the impact that the staff had to face because of COVID. There was a lot of burnout. We had stress. There was a lot of stress, of uncertainty. I'm sure you had that in Delhi and India. Kal kya hoga? What's going to happen? Is COVID going to hit me? What if I passed somebody in the corridor and that person wasn't wearing a mask and he coughed? Did he have COVID? So I can tell you my experience. I was on the unit and I came out and there was somebody who was coughing in the corridor. That was fine. I think I passed him. I went home. 2 days later, I had a bit of fever. And I must have, I just sat there and I said, Baba, this is COVID. Tere ko COVID ho gaya. You're going to get. Now, fever lasted for 1 day. I went and got myself tested and it was negative. But I can imagine the kind of stress, not just me, but a lot of doctors and nurses were having. So we asked our psychologists and said, look, can we put something in together to actually prevent some burnout and prevent some, build some systematic resilience? I don't know. Vikram is there on the screen, but the stress and resilience programs, a lot of them are telling you what to do. I think that's a problem. In the sense, don't do this, take time off, sit back. These things are good in principle. In practice, when you're anxious, it is very difficult, right? So we decided to start a project which is decrease self-reported burnout and stress-related sickness. And of course, throughout the neonatal unit, and this project is still ongoing, and it's for 12 months, and we are following this cycle. We use a framework which is called reflection, curiosity, and change. We had so many frameworks, I cannot tell you about improving resilience, but we chose something which was developed by one of the leading psychologists in London. And what is the strength of this framework is it empowers staff to look into their own minds, to reflect, to become curious, and to then bring change in their own behavior. So instead of telling people, what we do is the program helps people take charge of their own mind state. And I think that was the biggest and most important thing. That's why I liked it. And I encourage this by the psychologist. We've got something called interrupted service search series design. We're going to look at number of problem events. And then once once the psychology becomes embedded, we will see that the number of problem events goes down. So that is the idea. So I'm not going to go into a great detail into this because it's a very complicated project, but I just wanted to tell you how it is done very briefly. We identify influential systemic factors. We identify priorities for change, facilitations and barriers to implementation, and key indicators of success. We then identify potential intervention targets, and then we have something which is a process-related outcome. I'll just wanted to share you what this actually means. What is it? People say, "Kya actually ho kya raha hai?" So what is it? So these are the type of questions we ask people. What words come to your mind when your experience of working in the unit? How does it vary across different parts of the unit? What is the experience? There was lots of questions we asked. This was mainly to do about reflecting. When you are under stress, you don't reflect. You just do all day and night. So this is take a break, have a sit down, talk to a facilitator, and we encourage you to reflect. What are the priorities? And what's important is to what extent ways of thinking form part of everyday thinking in the unit. Ways of thinking could be, we are going to do things this way. Ways of thinking could be, this is the way we solve a problem. We solve a problem by getting angry or telling people this is how it should be done. We solve a problem by taking people into confidence, being polite. So there are many ways to solve a problem. There is a solution at every end, but we ask people to reflect upon how problems are solved, how people think. And then we ask them to identify pillars, 5 pillars, which particularly influence your current experience. You ask them to draw an image of the unit, what would it look like? And it's a very in-depth piece of work. We encourage the next part visits curiosity and curiously explain and reflect upon what we are doing. And then we say what are the changes that you can bring, and what changes you think can be brought in the unit, and what can be brought in you. So the process of reflection, curiosity, and change, these three in combination have shown in research to have a tremendous impact on burnout. We know that one other hospital in the UK has cut staff sickness and reported stress by about 50%. So this is still ongoing. I don't have results to share with you, but I can just tell you that it has been a very positive experience. I mean, these are the three projects that I wanted to talk to you about, and I wanted to thank you. Just to briefly recap, COVID is undoubtedly a big challenge, but I think what we can do is still maintain principles of quality initiative, QI initiatives, and how do we do them? Follow the plan, do, act cycle so that we can, learn from the initiative as it is going on and improve upon it. But but also make full use or exploit a crisis. As much as the crisis is exploiting us, we should be in a position to exploit the crisis for our babies and mothers and our staff members. So those are my three projects. Thank you very much. I've left a last bit on it, which is the Oxford Fellowships. Please don't forget, these fellowships are still on. We are delighted to receive applications, and if anybody's interested who has done their MD or DNB, please feel free to contact us, contact me, and we will let you know when we have the next interviews. Thank you.
Thank you so much, Amit, for that excellent presentation. And also the icing on the cake was the announcement about the fellowships. I'm sure many of our young colleagues would be highly interested to know more about the fellowships and also to get a chance to visit your fantastic unit and gain some insights. Many of our students have given wonderful feedbacks of their training abroad when they have returned. They've done tremendously well in improving the quality of care in neonatal healthcare across the country, right through the decade. So I would request everybody, in case people are interested in knowing in greater detail about the fellowship, they can leave their email IDs and details about fellowship in the chat box. And nice to see you, Amit. There was some glitch in the system. Thank you so much. So I think we can, Dr. Mehta, sir, we can also start the video now. So yeah. Okay, so I will start the question and answer session. It's a brief interaction, and I would like to start by congratulating you, Amit, regarding the antibiotic corner and the OPD-based antibiotic administration schedule, which you started in the COVID times. Well, I would say that in a short period of 6 months, saving 196 bed days in a hospital as busy as Oxford means tremendously important. And I was just thinking if we could, extrapolate this to Indian SNCUs. There is a tremendous dearth of specialized neonatal beds in the Indian SNCU system. And that each district hospital has got a SNCU which is always full and it needs to, refer babies. Even hospitals like Kalavati Saran, where I work, Lady Harding Medical College, Safdarjung Hospital, all large hospitals in Delhi, they're practically full and we have to often refuse a lot of babies. Because many of the babies, like in my unit also today morning in my rounds, there were many babies who were just there for completing the antibiotics, or the moms are not discharged from the gynecology side and they are completing their antibiotic schedule. So lots of beds, NICU beds are occupied. So my first question to you in this background is, what do you think? Can it be generalized to Indian SNCUs? And the second part of this question is, can you envisage continuing with this? Now you got the evidence. Can you envisage continuing this beyond the COVID era also?
So thank you, Vikram. I think there are lessons to be learned for everyone. So your second answer first. This will continue beyond COVID. So this is now going to become a standard for us. And I think this is an important thing because what came out of a crisis has now become a standard practice. We will not go back to what we were doing previously. So that's number one. Number two, I think it can very easily be implemented in India. I can't see why not. We took some risks. We had this question of, babies being at home and if they were becoming unwell and if the parents didn't understand how unwell they became. So I think the challenge in our setting would be to make sure that a leaflet is given to mums and dads in Hindi or in whichever language they're local, to watch out for signs. What are the signs we need to watch out for? That's number one. And we made sure that every mother had it. Secondly, I think it requires a little bit of organization into setting it up, who's going to give it, and making the protocols very clear. I think our strength in that is that everything has to be detailed. Where do you enter? Which turn you take? What is the door number? What is the number you ring if there is a problem? Where are the cannulas kept? How are, everything is in minute detail. And what you have got to do is not rely upon, creativity in once it's implemented. It has to follow a very strict guideline. And that guideline, we trained, very short training, but we implemented that. I think it has a potential to save a lot many bed days, especially our quick audit, Vikram, which was very important. We looked at 6 months data. I and my colleague Mark, we sat down and looked at 6 months and we said, how many of these babies actually do have respiratory distress after 3 days, after 4 days? Can they be discharged home? And we found that a lot of babies could go home. And what is very interesting is some of the babies had 7 to 10 days, even 12 days antibiotics. These are babies who had possibly a positive LP, and so it can be done. Data should be very well connected. We've got a safe subset, but I think as long as you are able to monitor the data, I think it can be applied widely. I think. I think it's something that is very good in terms of safety and efficacy.
So I think, thank you so much, Amit, that we have a lot of neonatologists in this group, and we also have the funding partners from UN agencies. We have Dr. Rajesh Mehta also here from WHO CRO.
Yeah.
So I think it would be a good idea to build up on your experience and see if we require any contextual adaptations. And we could also take this forward with maybe the additional commissioner for child health and try and see if we can integrate it on a small pilot basis into some of the SNCUs, of course, with the ethical approvals, etc.
Yeah.
That brings me to a quick second question, and then I open it up. People are requested, the participants are requested to please key in their questions with their names in the chat box. I will be taking them very quickly, one after another. So my next question is, you want to do something like this in India, the things where it gets stuck. And yesterday, after you left the journal meeting, there was a long discussion on the ethics part, of ethics and doing the QI projects and whether people should have ethical approval and what about parental consent. So that brings me to the next part very quickly. Did you seek parental consent that this was the standard of care before COVID? And this is the textbook recommendation. And now we are going to start with something which is not textbook based, which is being tried on an experimental basis. We are trying to do this. Do you give us your consent? And what about the ethical approval from Oxford?
So first of all, before we launched into that, what we found out that Ceftriaxone is used. The FDA had approved it for newborns, and so IV Ceftriaxone could be used. There was no ethical issue with using that. The challenge was that we were doing this from home. That was the big challenge. And so we didn't have time for going through the ethics for that, but we did explain to parents that this is something we are doing. Um, and if parents were not comfortable, we were not sending them home. That was also important. If mother said, look, I'm very anxious, I don't want to do this, that's fine. But but I think, one of the things that happens when you are in a crisis, that the usual pathways become shortened. I wouldn't use the word shortcuts, but I think the mind becomes very focused on the very pragmatic things. We made sure that the monitoring of the babies was very good. So anybody had a problem at home, that person had a phone number to ring us. And we made sure that parents understood it. And we made sure our doctors and nurses understood very well when these patients came to our clinic. So apart from that, we also had the strength, the evidence base from the audit we had done, where we looked at the general condition of a baby at 48 hours after antibiotics, and we found that to be generally good. We also safeguarded ourselves by making sure that the baby who goes home is fit for discharge. And that was very important. You see, many of these babies had just one dose of antibiotic, which means they stayed in hospital for 4 days out of 5 days. Many of them stayed in for 3 days and had 2 days at home. But that is simply because we wanted to be very sure that the babies were well. So short answer is we did not seek ethics because we were changing practice, not sort of experimenting with a drug. And we tried to pad it as much as possible with safety features. That's what we did.
Thank you so much, Amit. I think so that reiterates, I think, our conversation yesterday, which I was, for people in this group who were there in yesterday's BMJ Journal authors meeting. We had a large meeting for the prospective authors for the upcoming BMJ South Asia edition. And there was a lot of debate on ethics, and we had the Secretary of Ethical Committee, Lady Harding, sitting there, Dr. Harish, and he was advocating for ethical clearance before we start the QI projects. And I mentioned to him that 3 of our papers had gone before the ethical clearance, because we just wrote in the journal that's a hospital-based, system-based improvement authorized by the government, and the consents have already been in place, because we don't require a formal ethical. Of course, you have some interventional study, you do it. So I think that reiterates that in times of crisis, in times of the patient's welfare being primary, and taking the patient's attendants or parents into confidence, I think you can proceed ahead with the QI. projects.
May I just add, Vikram, for
Yeah,
QI projects, we don't usually go for ethics
yeah,
because QI is improvement of quality based on existing evidence. It
yeah,
is not looking for new evidence in the
definitely.
strictest sense. So
Thank you, Amit. I think that clarifies a lot of doubts for a lot of people who are common between yesterday's meeting
yeah.
and today. Thank you so much. Amit, I am very pleased to welcome here Dr. Rati Balachandran. Dr. Rati Balachandran is the ADG Nursing. In fact, she is the key person in the Ministry of Health and Family Welfare sitting in Nirman Bhavan in New Delhi. And she's looking after the whole nursing fraternity in the country, the administration and all the affairs, and also leading a lot of quality improvement initiatives and helping NQOCN, spread the message of QA across India. So Dr. Rati wants to ask you a question that are there any opportunities for neonatal nurses in these fellowships, or have you planned that in future you do something like for the doctors, you do something for the nurses also?
I think you see one of the challenges we face with the nursing issue is that for nurses we need the nursing council to approve of an exam that the nurses have to sit. So to come and work, you need to pass a licensing exam. Whereas for doctors, if they have their MD or they have their DNP, that license is given automatically. So I think that's a big challenge. The second challenge for the licensing exam is the English test, which sometimes is a very difficult test to pass. So those are the two challenges. So working as a nursing fellow is not easy for those two reasons. If there are nurses who can pass those tests, um, you know, there are hospitals in the UK who are desperate, I'll tell you, desperate for neonatal nurses, including my own hospital. We are desperate for nurses to come and work. The chances are that most hospitals will encourage you to never go back to India. That is the big thing. So licensing exam is an issue, but as far as observerships are concerned, if you want to come and observe, well, they are open. You can come and observe, but the problem with that would be the cost. You would have to bear your own costs, and that is very expensive in the UK. I'm hoping.
Thank you so much. So, Dr. Rati, any other questions, and how I think using your influence, you could facilitate, you could work closely with Amit
Yeah.
and also with Nursing Council of India. And I'm sure next time Amit comes here, we will connect you to Dr. Rati, and maybe together both of you can work something for the neonatal nurses of the country.
Thank you, Dr. Vikram and Dr. Amit. Through the Trained Nurses Association of India, some initiatives are there with NHS, so that there are some places it is exempted, and some other schemes like learn and return, something like that is also there, where the people are going there and working for some time and then return. So what I request is that if you can connect me with some of the neonatal nurses, that would be of a great help for me. And I think that will be more feasible from your side.
Absolutely. So, Dr. Rati, what I would say is that because I've been focusing on the medical side of things, I would be very happy to connect with you. I think if there are these opportunities available, I think we should exploit them. There's no doubt. Coming and learning and returning is a good option. If there is something which is available, I would be the first to try and push it and make it happen. So if there is that opportunity, I'll find out, but please connect me through Vikram and we'll have a longer conversation.
Definitely. Thank you so much, Amit and Dr. Rati. We will take it forward. And let me just reiterate here, Amit, that we are already in advanced stages of conversation, Rati ma'am, with Dr. Amit and nurses, neonatal nurses from Oxford. And in the month of December or January, we will be having an exclusive session with the neonatal nurses. And I think that will be a good opportunity for our nurses from India to connect with the neonatal nurses from Oxford. And by that time, I think we can also take this forward at your level and Amit's level. So I will now move to the next question, Amit. We have a question from Dr. Kedar. He's one of the founding members of NQOCN. Dr. Kedar wants to know, how did you motivate everyone? What was the method which you used? I think he refers to the first, part of your QI project, and also the second part in which you used the tablets and you did a short QI project for that. So Kedar is working on the psychology of change framework for NQOCN. So he wants to know that from you. The steps, how did you motivate, and what was the method, especially in times of COVID?
Thank you, Dr. Kedar. I think what I think is the main motivator is an empathetic understanding of how difficult a job it is for most of the neonatal staff. And our nurses are specifically and especially bearing the brunt of any crisis. So the motivation first starts with an empathetic understanding. And I think that's what we did first, is not tell people this needs to be done, but have a discussion which is much more democratic, much more, I would say, which takes everybody into account and make suggestions. And almost the way I think this worked is you bring the discussion to a point that it becomes a suggestion from people who are going to do it, almost to that extent. So you start the discussions in very exploratory means. The second thing in motivation, which I think for a specific project like ours, was to highlight the benefits that will happen towards for babies. And the kind of those benefits should not be woolly, should be very clear. This is the kind of benefit we will have, and I think that makes a difference. I think those are the two things that I would do. But what doesn't work is just telling people, this is the QI project, this is what we're going to do, here is the guideline, please follow it. That doesn't work, because you've got to spend a lot of energy, psychological energy, going and speaking to lots of nurses. And that's what we did. And nurses, I say specifically nurses, but nurses and doctors. Doctors are much more amenable to discussion, in the sense that because they are medical colleagues, your colleagues, so you sit and have coffee with them much more frequently than you sit and chat with nurses. But I think if people feel that they own it, they own the project, it works much better, much better. So a lot of ownership invested in it, and not checking upon the project as if you are interrogating someone. It really pisses people off. Is empowering people that, look, this is a serious responsibility, and this is how you do it. And please do tell us how you feel, and do tell us if there are any problems, and check on them gently. Can I say a third one? A third one is make sure that the team is well recognized. So yes, we would have started it, but the nurses who were running it, who were key in running it, although they just ran the project, we made sure that they will, if there's a paper published, they'll get authorships out of it or something like that. But even for simple things, I think making sure that they are well recognized within the unit for doing something like this. Those are the simple things.
Thank you so much, Amit, for giving your practical insights and these tips for motivating the teams. There is a question from Dr. Ajit Sutke. Dr. Ajit wants to know, what indicators were you tracking for the second QI project, that is parental connection with babies using the tablet?
I don't think, honestly, we had a very great number of indicators. We responded to a crisis that the mothers were facing. And there was a huge amount of psychological strain, because when only one parent was available in the beginning, the mother who has just delivered a preterm baby is not able to manage her stress. There's no dad around. Many times her mother was, a mom's mom, they were not around. So what we did is we simply took feedback at the end. That's all we could do. we know that one method of tracking how successful was the demand we had for videos and photos. We were bombarded with demand that I want to see my baby's photo and I want to see the video. That's why we got medical students involved. Now the demand is coming down, which is because the need has come down a little bit. It'll rise up again, but for the time being, the demand has come down. And that demand was a stress-related anxious response.
Understand. There's a question from Surinder Besh. Surinder is the managing editor of Journal of Healthcare Quality and in-house journal with NQOCN and also a governing board member of NNF. Surinder was in the Delhi NeoCon a short while ago, and thank you so much, Surinder, for making it to attend this webinar session here with Amit. So basically, Surinder wants to know, he wants to know when you said cannula 10%, what does it mean? Only 10% need cannulation, or is this happening every 36 hours? Or what do you mean exactly by that?
Out of all the antibiotic doses we gave, 10% of them, 10% of those doses needed a replacement of the cannula. That's what it means. So 90% of the doses were given on the previous cannula, which was there. Because you see, that was another concern we had. The baby goes home with a cannula in sight and then the cannula comes out and then every time the baby comes in, we put another cannula. So will it last for 5 days? That kind of a thing. But it's only in 10%. So what we were very conscious, we didn't want to increase the workload. And so we didn't. I don't think 10% is a pretty okay figure. If the baby was in the ICU, I'm sorry, on the neonatal unit, that would have been similar.
So Amit, that brings one important question into my mind. Did you have any special education program for the mothers on handling the cannula at home and also preparing them for an emergency? What if the cannula got displaced and it started bleeding or it got soiled? You know, did you have some write-up which was given to the mothers or an emergency call number, or what to do in times when if cannula got displaced or the cap, it got decapped or something like that? Was some education program initiated before they were sent home, or they were just fixed and sent home?
I think they were fixed and sent home, but the cannula was wrapped by, they made sure that the cannula was wrapped and it was not open. That is one thing. So that, and made sure that everything was tight. But they always had a phone number. If there was a problem, they could always call. And we taught them common sense things. Look, if the cannula is bleeding, press on it, take a cotton wool, press on it. If it comes out, let it come out, just stop the bleeding with a cotton wool, give us a ring. That's all. The baby is not going to bleed, exsanguinate with a venous cannula, which is in the hand. So just commonsensical things. Actually, we didn't, you are saying this and I'm now trying to think that we went into it. But as the guideline is going to get modified, we will have some more of that information with some pictures. We didn't have that at that time, but that's a good idea. I think we should just do a little bit more in terms of that education. My biggest regret is we didn't ask mothers what the feedback was. What did they feel, after the antibiotic? Because we are going to start collecting the data now.
So thank you so much for that response, Amit. We have a question from Dr. Aarti Kenikar. Dr. Aarti is heading the Department of Neonatology and Pediatrics at BJ Medical College, Pune. Dr. Aarti wants to know, bringing students in for communication was an excellent idea. How much was your IT department involved in this project? Were NICU nurses involved in telephonic home communication with parents, but gone home and are coming only for treatment? So how much was your IT department involved in this project? And bringing students is a good idea, she says. And were NICU nurses involved in the telephonic home communications with parents?
So the first thing, the IT departments are very good, but they're very difficult. Anybody who works with IT will know that so our IT department was hardly involved in it. That's number one. If you're talking about the We Create project, the one with the tablet, this is a commercial venture now. So they started with us, and it's available as a commercial venture, and people can just buy the tablet, buy the app, and then just use it. So we took an off-the-shelf product which was there. So that's number one. We did not want to get into this thing that the nurses are phoning mothers, or that is too much. Nurses don't have time for all that. So we limited it to still photos and a small clips when the nurse gets time. That's it. There's none of this. The nurse is taking a video and then a FaceTime this thing call and looking at the baby and looking at you. We didn't have time for all that, and that became too complicated. So we kept it simple.
Thank you so much, Amit. We have a question from Dr. Ankur Sudan. Dr. Ankur is an advisor with NQOCN and also works for WHO and UNICEF in quality improvement in South Asia. Dr. Ankur wants to know from you, do you have quality improvement advisors in NHS trusts? If yes, then how have they been able to help or transition their work during COVID? Any ideas on that?
So there are quality improvement advisors, but we see as jobbing neonatologists, the whole QI movement has come quite late to us in Oxford, I must admit. Most of the QI that we were doing, or we still do, doesn't follow the good principles that are set out. We're learning these principles as we go along. So the plan the PDSS cycles that it's become embedded in our culture slowly. We just were using common sense. So, you do something, you do it, and then you see what it is, and then you change your plan. But we do not have specific QI advisors for the whole trust. What we do have is many neonatologists, pediatricians, physicians getting together and forming QI teams. We call them QI hubs in the hospital. They are the repository of training, showcasing projects, helping junior doctors and senior doctors to design projects, and helping them how to measure it and use all the science and education and research that exist in the NQN field to actually make projects better. So that is there within us. So we are tapping that resource now much more than previously.
So Amit, that brings me to the last question. I know it's been a long session for you, and you got another session coming up in Delhi in NQOCN tomorrow. So the last question is from Dr. Chaya Valvi. She is a National Mentoring Group member and a professor of pediatrics at BJ Medical College. She wants to know, have you had any follow-up of these babies? I know it's a short time, like I'm sure she's talking about those initial antibiotic guys, the ones who got antibiotic on OPD basis, home visitations. So these guys, have you had a long-term follow-up, any long-term, or are you planning a long-term follow-up for these guys?
So, ma'am, what we are relying upon, so the reason we didn't have a long-term follow-up for any of this is, first of all, it was impractical to do it. It's too expensive, very difficult and cumbersome to sort out. And what were we going to follow up? So the problem is with these large, most of them are term babies with infections, which are treated. We relied upon a system which exists in the public health. If there is a problem, then the parents would be alerted to us, they will come to us, and that was all we did. So it is very unlikely that some of the babies who were in the region who benefited from this became sick later on and ended up in a different hospital. We were very conscious and careful about that because we are the only hospital in the region whereby babies can come. So we were not losing these babies. So there was no fear that these babies are having 5 days antibiotics at home with us, and by day 10 or day 12 were getting admitted in London with infection and dying there. So that was not possible. So we did not have any long-term follow-up program at all. We just had a very practical, simple program. Go home, if there is a problem, ring us. And parents were educated about this. Everybody got a very nice leaflet, And that's very important. A very nice leaflet explaining what was it. And there was a telephone number. Yeah, that's all we had. We are not planning a follow-up either. I don't think we would.
Okay, but definitely you're planning to take this beyond the COVID time, and I think that has good implications for a country like India. Like we are talking about our national SNCU networks, also our busy neonatal.
Yeah, Vikram, I remember going to Sonipat, I think many years ago. It's a beautiful SNCU.
Yeah, and it's an NF accredited SNCU. In fact, I was there many years back.
Many years back. And you know, places like that where they have got a good team, the amount of not just COVID, I think COVID is an important point. I think the amount of money that people could save in hospital admissions and being on the unit and sitting there, that itself is quite a lot. I think you're freeing up your maternity beds. You see, we're talking about the neonatal benefit, of course, but you're freeing up your maternity obstetric beds to a great extent, especially in the semi-rural, in the small towns we have, where the maternity services are stretched. I mean, North India, I know that the institutional, what do you call the institutional delivery rate is lower than the South. We want more obstetric capacity, and I think this making this a neonatal project is only part of the story, Vikram. This is much more wider than this. Is much more of an obstetric viewpoint also. I think that there is a lot of benefit from creating that extra space. Yeah.
Definitely. So thank you so much, Amit, for that interactive session which we had, and I think it has given us a lot of insights and ideas also for innovative QI projects. And I think lots of mentors in NQOCN would have taken cue for it, and this is the purpose of the communities of practice, to bring together experiences from across different nations on a single platform to catalyze, similar quality improvement interventions which can be generalized in different contextual settings. So I would now request Dr. Rajesh Mehta for the concluding remarks. Rajesh Mehta, sir.
Yeah, thank you, Vikram. And thanks for creating these opportunities to bring brilliant people like Amit to the community of practice here. So thanks, Amit, for sharing your your own system-oriented projects. And it is very easy to, compare and then see each system is designed differently, and the priorities can be different. So here, if Dr. Surinder doesn't get his salary from the government for 4 months, and nurses are not getting salaries for 4 months, obviously the situations are different. But I do admire your ability to convert this crisis into an opportunity, and building it back better is a constant phrase, and you gave an illustration that you can improve and make it more efficient by using this antibiotic at home approach. And I also particularly like the human touch which came through parents and the pictures, and also about the healthcare workers' own psychosocial well-being. So that human touch is critical in the phase of crisis, and that reminded me of a lot of PTSD, post-traumatic stress disorder we had to support after each emergency or a disaster in communities as well as in healthcare sector. So keep doing, and then these are inspirations for our people here to find their own priority quality improvement areas and deal with them. So these are obvious successful examples, are very motivating. So I'm very happy that you will continue this Ceftriaxone and even discharging early. For us at Public Health, as WHO, we have recommended syndromic treatment for neonatal sepsis for babies who cannot, who need to be referred, but referral is not possible. So in the interiors of India, and yet we found 2 days injections of gentamicin and 5 to 7 days of amoxicillin is equally good compared to what they would get the standard treatment, right? So now I am tempted to do the same in hospitals. If they survived a subset of newborns with this regime, simplified antibiotic, why can't that be done in hospital also for a subset of babies that only 2 shots are given and rest is home? And then also, of course, you exclude a lot of critically ill babies to do that. So those are the advances which need to come back. Until we have a point of care test to diagnose sepsis, mostly we are going to be syndromic only. So therefore, there are opportunities in this, and I thank you for your presentation.
Thank you so much, Dr. Mehta, for those insightful words. And I thank all the participants for taking time out